to bring that mic way down. There we go. Can anybody see me over the podium? Yeah, I didn't do the short stature talk, but I could from personal experience. So first off, I want to just apologize. I'm getting over some terrible cold, as we say in Texas, la gripa. And I'm hoping it's not my nurse that gave it to me. Where are you? No, she knows it's not her. Anyway, so going to talk about a couple of topics. I'm obviously very, very proud and excited to come to Little Rock. Part of the reason I came here, and not just because I adore John and this great group and this wonderful hospital and this fun town, but I wanted to build something here. And so we have practically from the day I got here been working on building the Transgender Clinic. And so I wanted to speak to you guys a little bit about that experience and what we have to offer. And then if there's time left, talk a little bit about bone, because those are sort of my two areas of interest. Now that we've got the Transgender Clinic up and rolling, we're now in talks to start a more formalized bone and mineral metabolism clinic. So I'm excited about that too. Email address is up there. Write it down quick. Sorry, you're too slow. Sadly, nothing to disclose. Okay. So first I want to brag about some of the folks that are on my team. We really take a very holistic approach to the transgender child, and I mean holistic in the real sense. We're looking at every aspect of the child's health and the family structure and the health of the family, and this has just been a really unique and very sometimes difficult, sometimes trying, sometimes confusing, but incredibly rewarding experience, I think, for all of us, and I think everybody who's part of the clinic would say the same thing. But we follow very, very much what's called the W path, or the Dutch protocol. So the very first transgender clinic for children was in Amsterdam, Holland, hence the Dutch protocol. It's not because we wear clogs and eat a lot of chocolate, although we do consume significant amounts of chocolate, but we have the requisite components of running a proper transgender clinic include having a social worker. That's really the heart and the soul of the clinic. If we didn't have I was told very early on, if you don't have a social worker, don't even try, and they were absolutely correct. So Kirsten's not with us today, but she's absolutely the heart of the clinic. I like to say that the soul of the clinic is our chaplain, Kenneth, and he really brings a lot to the experience as well for a lot of our families who are really struggling. How do you bring these two disparate things together? How do you make sense of it? He's been very helpful for a lot of our families. We have all of our patients go through a full psychosocial assessment. So Sherry Gaudette, Sherry, are you here? I know you registered. I don't see her. So Sherry Gaudette's been very key to making sure that we really get to know these kids well, and that we're identifying any, what I call bear traps. You know, you're walking along, you stick your foot in a trap and it closes on your foot. We like to try to identify those bear traps before we put our feet in them. And so that's a huge, huge part of that process. Sean Adams is our specialty nurse, who has really had a learning curve about that steep, right? And she's just done great. She's really stepped up to the plate. We also, I'm very proud of the fact that we have somebody from the Medical Legal Partnership who comes to almost every single clinic. And when she first came to join us, well, actually we had Spencer first, but now we have Hannah Roy. She's fantastic. I thought, well, this will be kind of cool. Almost every single patient has needed services and help from the medical legal group. So really, I think we can really take care of these, not just the children, but the families, because we can handle custody problems, we can handle divorce issues, we can handle the fact that the school's not letting the child use the bathroom. These become legal issues that really I don't know how to address, and so having Hannah on board has been fantastic. So some learning points for you guys. I really want you to really better understand what is gender identity disorder, what is gender dysphoria. They're not necessarily identical terms, but what is it? And really help you guys help build a more supportive and inclusive environment for your patients. Because I guarantee you've got some in your clinic. You may just not realize it yet. And then again, talk about our clinic. So I really like this slide. I found this cartoon several years ago, and I really think it sums it up what a lot of our kids face on an everyday basis, and that is just the simplest things, such as going to the bathroom. And they're thinking, if I go in the girls' bathroom, I'm going to get yelled at. And if I go in the boys' bathroom, I'm going to get beaten up. Not a real exciting choice. And so what we find is that a lot of these kids literally they don't drink anything, and then they hold their urine. And we've had UTIs and a couple of kidney stones already in these kids because of what they're doing, holding that urine. And so this is a real problem. But I think this cartoon kind of sums it up, that what these kids face, just minor things that we don't even think about, become struggles for them. what is gender identity? It's very, very different from sexuality. I really like the quote that's on this slide. I don't even have to look at this slide because I've said it a few times, but this quote really sums it up. Gender identity is who you go to bed as. Sexuality is who you go to bed with. And I want you guys to leave here with at least that one understanding that those two things are very, very different. And they're not necessarily related, and one does not cause the other. And the majority of our patients who have a gender identity that is not the same as what they were born into, most of them identify as heterosexual, okay? So it's important to get those two concepts kind of separated in your mind, okay? This is a cute little cartoon that you guys can look up if you want to look at it later, get a little bit more understanding. It kind of gives you a sense of what different ways of looking at gender. As an endocrinologist, we have actually about 15 different ways we look at gender, right? Genetic, hormonal, phenotypic, then there's identity. Sexuality to me is way down on the list because to me sexuality isn't even really a part of gender. Okay, it's independent of gender. But we as endocrinologists, really, especially for the folks who work in the DSD clinic, Dr. Bonsall and Dr. Oden, have to think about some of these questions when they go to that clinic on a very, very physiological level. You know, when you have a baby with disorder, with unclear, ambiguous genitalia, right? So that's the medical side of it, but most of what we're dealing with is not something that you can test for. You can't draw a hormone level to figure out if somebody has a gender identity disorder. It's just very much we don't know what the cause is, but we know it's real. I believe that it's real now that I've been working with these kids for this long. So what is transgender? That's just a term, an inclusive term that basically describes people who do not identify with the gender that they were born into. And so they feel very strongly, the same way that when I was a kid, I didn't have to think about whether I was a girl, I just knew I was a girl. It's the same for these kids. They know from a very early age in many, many cases. But when they look down, it doesn't match. And that's what causes the dysphoria. So the dysphoria, in my understanding, is secondary to the fact that we're not fitting the gender that we see when we look in the mirror and when we unfortunately look in our underwear. I have some of our kids are so dysphoric that they can't even shower, or they shower with their clothes on. I mean, you hear some really unfortunate stories, and that's how severe sometimes the dysphoria can be. Okay. Cisgender refers to somebody like me, unfortunate that I do match the gender I was born into, and so I consider myself cisgender. So those are the sort of terminologies that you'll hear used. Great question that people throw around and ask me a lot. How common is transgender? Oh goodness, nobody really knows. But I can tell you, if you look over the years, over the last 20, 30 years, that number keeps getting larger. And I think it's because some of it is ascertainment bias in terms of how we ask the question. And some of it is just, I think a lot of these folks, both pediatric and adult, are feeling more comfortable coming forward and saying, I'm transgender. And I think, seeing a lot of movie stars and famous people coming out and being brave and doing that in the media very openly has emboldened a lot of our children to be able to do the same. So there is some concern. I have a lot of parents come to me and say, is this a phase? Is this real? And, I can say we have to take each individual child as a separate case, and we're going to do that with each individual family, with each individual child. But is it real as a phenomenon? Yes, it's real as a phenomenon. And what's really striking is that some very recent surveys show the prevalence rate as high as 0.6%. I think that's maybe a bit of an overestimate. That particular survey asked a kind of a more loose, open question, and it included people who are perhaps a little gender fluid or asexual. It kind of included, it was a more all-encompassing question. I think that the actual prevalence rate is probably somewhere between 0.2 and 0.6%. That's a lot. That's a lot. And to give you a sense of just how real this is, when we first wanted to open the clinic, we were told by every other clinic in the country, get ready, you're going to get way more than you expect. And that's absolutely what happened. We estimated, we thought we might have 40 kids by the end of a couple of years. We're over 100. And that's without advertising of any kind. We've done no advertising. This is completely word of mouth between these families and these kids. So that should give you some sense of what the local prevalence is. These are some famous transgender folks. You probably recognize most of them. Some of them are actors, athletes. I kind of dig the guy on the far bottom on the left. That's Outkast. He's a rapper in New York. And just going to show that they span the whole gamut. And these are often very smart, very driven, very ambitious people, and I'm seeing the same thing in our clinic. These are really funky, cool, just driven, exceptionally smart kids. And I don't know if there's an association there between transgender and being smart, but it seems to be the case for us. Okay. Who in this room, I mean, which kid is the transgender kid here? They're twins, by the way. Can anybody tell? The only hint is it might be the one with the green hair, right? Because she's kind of funky, she's got her hair green, and she did wear her hair green for a while. So these are the Maines, and they were actually originally from Maine, which is kind of funny. They were identical twin boys, same uterus, same, everything's the same. They were in the same sac, and yet one of them is transgender, one of them is not. So if that doesn't boggle your mind in terms of thinking about what the cause of transgender is, I don't know what will. But this one is a great example. She's actually pretty famous now, and she is, I believe she's in Supergirl. It's one of the TV shows. All the kids know it. I've never watched it, but she's actually a famous actress now, which is kind of neat. There's a great book, if you're curious, called Becoming Nicole. It's about her parents' experience. It's written more from the parents' perspective, which is really quite fascinating. But I love this slide because, not all of our kids are going to go on and star in a TV show, on a famous TV show. These are regular, normal, just normal kids. Every kid in this picture is a transgender kid. These are just normal kids. But they face a lot of challenges, okay? And one of those challenges is the high rate of suicide. And we have already here in our hospital in the last 3 years had 2 children complete suicide. These were unfortunately children who had not yet made it to our clinic because their parents were not supportive of their transition. And I think that's a real shame, for lack of a better word. It's just a shame and a tragedy, really. So one of the biggest things that we do is we do consistent and ongoing assessment of suicidal risk. Kirsten spends an awful lot of time doing this. I've gotten better at doing it. And we stop if we have to, and we sit down and do safety plans. And there was one night where we were kind of finishing up clinic, and we had 3 kids, all suicidal at the same time, and Kirsten and I were there till 8 o'clock that night doing safety plans on all those kids. It's just what you gotta do. I think we made a difference. I really do. And I think we do make a difference with this clinic, and that's what makes it really great. So in our clinic, we have had, these are the percentages of our particular clinic. So you can see that our kids are reporting suicidality ideas at the same rate as what's been published in other places. And I know John's sitting there going, and are you going to publish? Yes, we will. We'll get there. Okay, it's not just suicide. There's other problems these kids face. Self-harming behavior. Lots of these kids cut. I would say so many of them cut. Homelessness is a real problem. We've actually had a couple of kids face this problem. Some of the older ones, thankfully not the younger ones. A lot of these kids drop out of school. They're getting bullied there. They're getting harassed, physically assaulted. They can't use the bathroom. Nobody's using their real name or their preferred name. And so they just drop out of school. That's terrible. What happens to a young kid who drops out of school? They become a target for horrible things like drug abuse, trafficking, and the sex industry, etc. And all of these things are real, and they're right here in Little Rock. So our own kids are facing these same issues. I need to update these numbers because none of our kids have, a little bit of illegal drug use, but we haven't yet had anybody admit to prostitution, thankfully. But we've had a lot of assaults, sexual assault, violence against our kids. These kids are really at risk. Okay, this is from our clinic. This is our data. Because I started noticing early on that the kids seemed to fall into 1 of 2 groups in terms of when they became aware that they were transgender. And I don't think I've ever seen this reported anybody else, anywhere else. And I need to update this. This is relatively early on. Our kids seem to fall into 1 of 2 groups. They either know they're transgender practically from the time they can speak, or it happens right around the time of puberty. I have some theories as to why that is, but I think in a lot of cases, the brain, when it gets hit with the sex steroid that it's not ready for, that's when a lot of the dysphoria sets in. And when they start to see their body changing and it doesn't fit how they feel, that's when a lot of the dysphoria sits in or hits. So I think that's why some of the kids just, for some reason, seem to know from the time they can speak. For a lot of the others, it's right around the time of puberty. And that's why you see that sort of bimodal distribution in terms of when they become aware of it. The onset of puberty is a very common time. Okay, so not that long ago, there were only 2 clinics associated with pediatric hospitals, so academic medical centers, that provided comprehensive care to kids who are transgender, and it was Boston and LA. Look at us now. And of course, the fancy rainbow butterfly, that's courtesy of Kirsten, and that's us. And we're so proud to be a part of this illustrious group. Okay, just a quick, we can kind of run through this quickly. I don't want to waste too much time on it, but just to give you guys to let you know that we didn't just throw it in. We really spent a lot of time working towards this, and I don't believe he's here, but I really want to give a big shout out to Greg Adams. Anybody here knows Greg? If we ever name this clinic, we'll call it the Greg Adams Clinic. Not kidding. He's really helped build it. He's the one who identified the stakeholders, brought the stakeholders in, organized those meetings, got everybody on board, really made it happen. And then he was happy to sort of, like, okay, I've delivered the baby. Yeah, I'm not going to do it anymore. It's all on you guys now. But yeah, I still think, when I think of this clinic, I think of Greg. I need to update this. We're now over 100 patients, and we now operate 4 full clinic days a month. We started with 1 little measly half day a month, and now within 2 years, we're already doing 8 sessions a month. We've gone from 1 to 8 sessions a month in 2 years. That tells you something right there. Okay, so the protocols, we're not making this up. We're not kind of just figuring it out as we go along. There are multiple published protocols on how to treat these kids in a comprehensive, safe, and scientifically sound way. And those protocols are present from, as you can see, multiple different sources. And so we do follow our own version of the WPATH protocol. What does that mean? They get an initial intake over the phone with with Kirsten, our social worker. She helps them manage. This is, I don't know about that. I think this is true for medicine in general, but I think 80% of what we do is expectation management, right? As pediatricians, we do a lot of that in this clinic. So that's what she's initially doing on that initial phone call. What are the parents' expectations? What are the kids' expectations? Let's start managing those right up front. First of all, no, you're not going to walk into clinic and get testosterone the minute you walk in. So that's a big one right there. So we try to deal with that before they show up so that they're not disappointed. They get their intake, they come and they meet us in clinic. That is a wild and woolly clinic because it's got a lot of moving parts, and we like for the families to really meet everybody. So we have a huge dry erase board with everybody's names and the patients in the rooms, and somehow we make it work. It's a little bit of herding cats, I think is a good way to put it. It's a bit like that. Once we get to know them better in clinic, and we know that they're set up with their own therapist, it's an absolute requirement of this program that they be in ongoing psychological therapy with a therapist near home who is gender affirming. And I'm very, very proud to tell you that we have built a really extensive list of fantastic therapists all across the state. And that has really been a large part of what's made this clinic possible, is that the therapists are out there actually taking care of these kids every week. And we couldn't do it without them. And I'm so glad we have that long list. Thankfully it gets longer. We offer that full psychosocial assessment with Sherry Gaudette. That's looking for the bear traps. That's what that's all about. So that we can, oh wait, mom's on board but dad isn't? Okay, we gotta get dad in here. Let's start working on that. Oh wait, you guys are in the middle of a custody dispute? Let's get Hannah in here. There's a lot of those little things that really matter in this clinic. We insist that they stay in ongoing therapy throughout the whole process. That's incredibly important. But from a medical perspective, initially we'll use, for example, a lot of Depo-Provera to stop menstrual cycles in our trans males. So those are our female to male transgender kids. Boys are not supposed to have vaginal bleeding, so it really causes a lot of dysphoria when they get their bleed every month. So we use a lot of Depo-Provera. That's a fully reversible therapy, so we can do that early on. And with our trans girls, the male to female, we'll use a lot of spironolactone and a little bit of agestin to bring their testosterone levels down. You know, a girl is not supposed to be having spontaneous erections every morning when she wakes up. That causes a lot of dysphoria. Just by bringing that testosterone level down, they come and they're like, oh my goodness, I feel so much better, thank you. Those are reversible therapies, so we can use reversible therapies early on. We don't even consider using anything that's non-reversible, such as cross-sex hormones, testosterone or estrogen, until the kids have met all the criteria as laid out by the WPATH program. And that's an international consortium that helps set up these protocols. They have to be of a certain age. The parents have to both be on board. They have to have gone through our psychosocial assessment, and they have to be in ongoing therapy. And even then, we still sit down and do a full consent so that they understand all the changes that are going to happen or may not happen to their body before we start the hormone. And after we've jumped through all those hoops, then we do that. And what's really fun, I've had a couple of kids on the day when they start their testosterone, for example, I had one kid look at his mom and say, hey mom, Can we walk by the store and grab one of those balloons that says it's a boy? Oh my gosh, that's so cute. Okay. I had another family that right after starting their testosterone, they went home and had a gender reveal party like you would have for a baby. I'm like, these are really great stories, okay? Fascinatingly, these kids report to me almost to a person that they feel better on their cross-sex hormones before they even see any changes in their body. That's amazing. So one of the next things I want to do in all my copious spare time, as my old boss used to say, that's a Perry White phrase, that I want to set up a placebo-controlled study and try to see if we can suss out whether there really is something happening at a biochemical level in these kids' brains. I think that would be very, very interesting, but I'll tell you about that in a couple of years. Okay. We do not plan to do any surgeries at ACH. I don't think that will surprise anybody in this room. But there certainly are surgeons out there who, for instance, will do mastectomies at relatively young ages, but we have no plans to do any kind of gender reassignment surgery at ACH. Once they age out of our program, we transfer them over to either UAMS or to Planned Parenthood, both of which have good comprehensive programs for adults. Okay. So I think we can kind of go by this quickly. I think you guys picked up on the fact that we're looking for suicidality, we're looking for risk factors, we're constantly assessing these kids, and making sure that they're in, that this is not, here's your testosterone, we'll see you in 6 months. All right? Okay. What can you guys do? So let's pivot a little bit. I will be honest with you, this is not easy. It took me months to get comfortable with using these pronouns. And you have a child sitting in front of you who for all the world looks like a guy, and you've got to say she. And your brain has trouble with that. It's like those pictures they put up where the letters spell red, but it's in green, and so you say green even though it says red. There's something like that going on in the head, I swear. But it gets easier the more you do it. And it really matters to these kids when you use the right pronouns and you use the right name. There are studies that show that their risk of suicidality and their dysphoria decreases if you use the right name. So if you identify these kids in your clinic, you might do a little sit down with your nursing staff and just say, hey, I know that this kid that's coming on Tuesday is transgender. Please use this name and please use this pronoun. It goes a long way, okay? If you make a mistake, just don't make a big deal out of it. All the kids have told us, yeah, I get misgendered a lot. The best thing to do is just say, oops, sorry about that, and move on. Do not make a big deal out of it. That tends to make things worse, right? Okay. So everybody, we all have the opportunity to make things better for these kids. And I know we can because we're already doing it. So please feel free to call us and let us know if you have any children, any families who are interested in coming to our clinic. Like I say, a lot of them already know about us because they all talk. But this is how you can refer to our clinic. So that number there, the 2935 number, is how you can make referrals directly to our clinic. We do not do referrals through the general referral program. We kind of a little bit separate. Okay. All righty. So that's it for transgender. I want to really quickly go through bone very fast. Did anybody see the Pete's Place from last week? I actually did a full Pete's Place last week on bone. So you guys, I think, can access that. Can you access the Pete's Places? Okay. So it's good. It really has everything that's in these next few slides at a much slower pace. Okay. So let me just skip this slide. Here's a key point. I want to just point out some pearls for you guys. Okay. Peak bone mass in children. You start building your peak bone mass around the age of puberty, and you're done by about 25. That's particularly important for our girls, because the way I like to put it is it's like putting money in a bank account. After 25, it is all withdrawals, especially for females. So you need to make sure you've made good deposits. So it's important to identify those teenagers who have certain risk factors for low bone mineral density, such as chronic illness, okay, amenorrhea, steroid use. There's others that we'll go through. So this is the key time, because if they're not making those deposits now, it's all down here from there. So what are those risk factors? Chronic renal insufficiency, CRI is a big one. Any kind of GI or liver disease, cystic fibrosis, we know about that. Certain endocrinopathies can do it. Neuromuscular diseases, especially if they're on certain anti-epileptics, can do it. Any chronic disease that requires steroids, Oh, let me tell you, the bone doesn't like glucocorticoids at all. Malnutrition can do it. Of course, a sedentary lifestyle with that much exercise, smoking is a bad risk factor, and that's a real bad one. And then there's the big one that I see a lot of in my clinic is disuse osteoporosis for children who are non-ambulatory. That's a big one, okay? And then there's the primary bone diseases that I may hit on a little bit. Okay. Nutrition is a big one. Lifestyle, smoking, inactivity. These are things that it's kind of low-hanging fruit. We can address these things without doing anything too crazy. So be on the lookout for those kids who, aren't getting any exercise, or maybe take a Depo-Provera, so you've suppressed their menses, or maybe they're having amenorrhea. These are problems that we can address, and we need to do it now and not wait till they're 30, 45, 50. Okay, just remember, glucocorticoid's bad. You don't even need to know why. They're just bad. Okay, seizure medications can cause problems too. All right, so there's some primary bone diseases that are really interesting. And the reason that I put these up here is I'm actually really excited about the fact that every single one that I've put up here has a potential new therapy coming out in the next few years. I'm not going to name them because I don't want to talk about off-label. We're not really using many of these right now because they're off-label. But osteogenesis imperfecta, right now we use a lot of bisphosphonates. If you send me a child with OI, I'm probably going to start them on a bisphosphonate and follow them with annual DEXA scans because that's the standard of care. But I think that standard of care is going to change very, very soon. Now, the interesting thing about OI, we know that OI is caused by collagen 1 mutations, but there's a growing list of other targets that, if modified, also cause OI because they're involved in the processing of the collagen. So that's kind of interesting. X-linked hypophosphatemic rickets actually does have an FDA-approved medication that helps bring down the FGF23 levels and really, really helps these kids grow and save their bones. Achondroplasia has a new therapy coming out targeted at fixing what's going on at the growth plate. And hypophosphatasia, which thankfully is very, very rare. This is a very dreadful disease where the children don't make alkaline phosphatase and they literally have the bones of a rubber chicken. And we have recombinant alkaline phosphatase out to treat that now. Thankfully, though, it's a very, very rare condition. So some common things, we talked about common risk factors. It's DEXA, not DEXA. You guys don't care about that. When you're reading a DEXA, okay, I do want to say one really important thing about ordering DEXA scans, guys. If it's not done at a pediatric facility, it's really not worth doing. When you do a DEXA scan on a child, the score, once they pull out what's called a Z-score, which is your standard deviation score, that has gone through multiple corrections, and you have to have the right software to be able to do that. So if you send a child for a DEXA scan to an adult hospital, you're going to get a number, and it's probably going to look bad, but it's not meaningful. So you really have to have those DEXAs done on a hospital that has the pediatric software. So if you want to send them to somewhere other than ACH, just check to make sure that they have the pediatric software, okay? So this is, I know you guys are really interested in this. Who do I refer? Okay, so according to the International Society of Clinical Densitometry, significant fracture history is 2 or more long bone fractures before the age of 10, or 3 or more long bone fractures. I think that's actually supposed to be 16. So if you've got somebody in their mid-teens and they've had 3 long bone fractures, 2 tib-fib fractures and a femur fracture, that's a kid I want to see, for sure. The next one that you need to worry about is any vertebral fracture of any kind at any age. Kids are not supposed to have vertebral fractures. So this is a good take-home slide because you're scratching your head. Well, who should I be worried about? We talked about the risk factors. Those don't necessarily mean you have low bone density, but if you have a kid who's had this many fractures by this age, that's who you want to be sending for a DEXA scan. What's the limitation of the DEXA scans? They ain't perfect. It is a 2-dimensional representation of a 3-dimensional structure. So for example, I kind of tried to draw these little things on the bottom that look like tubes. So imagine, your femur, for example, it's a tubular structure, more or less. And the DEXA will, in many cases, even though if you look at these different bones, give you a Z-score that is identical. For example, this and this might give you the exact Z-score. But those are wildly different bones. And in fact, just structurally speaking, even though the cortex is the same width on these 2 bones, this one is significantly stronger. And this is why we tend to see even kids with primary bone disease fracture less as they get bigger because of the larger structure of the bone. DEXA cannot reveal any of that. Okay, what can? By the way, the DEXA scan alone is a very poor predictor of fracture risk. So if you're worried about a kid and all you get on them is a DEXA scan, it's not great. Indications, though, we talked about the frequent fractures and any vertebral fracture, or anybody who's really at high risk. So the kids I'm really worried about are, of course, anybody who's had the large number of fractures or any vertebral fracture, but any child who's on chronic steroids, that child I definitely would evaluate. Children with chronic disease, non-ambulatory children need to at least have a screening DEXA scan. The DEXA scan has a much higher positive predictive value when you have these known risk factors, okay? Another thing to consider is if you have a child who is going to go on long-term steroids, should you at least consider getting a baseline DEXA scan to see, what's the quality of our bone before we start a therapy that we know is going to make it worse. Okay. Prevention, pretty obvious, vitamin D, calcium, and exercise, right? About the only treatment, unfortunately, we have in our armamentarium is vitamin D, calcium, and exercise, and bisphosphonates. But I'm very, very happy that I think that, here, these are in the slides, but you guys can get this stuff. People ask me D2 versus D3. Okay, D2 comes from mushrooms, D3 we make. D3 has a longer half-life. I prefer D3. You can use D2, it works fine. But there's a caveat, don't draw D2 levels, guys. I actually had a child sent to me at 6 months old for vitamin D deficiency because the D2 was low. Well, 6-month-olds aren't eating mushrooms, so I would expect the D2 to be low. I only check a D2 level on a child who's taking D2 to see if they're actually taking it. It's really the only reason to ever check a D2 level in the blood. Otherwise, I check 25 hydroxy vitamin D levels, okay? Okay, we don't really, bisphosphonates, we use them, it's what we have. If everything looks like a nail, if all you have is a hammer, everything looks like a nail, basically, okay? But I'm very excited that there's some new stuff coming out, which hopefully, in a few years, we'll be able to tell you more about. And did I get done in time?
Nope.
Yeah. I'm going a little over, sorry guys.
This is the most important one, and like an order that's better to draw those?
That's a great question. We have opted to not request labs for that reason and for the reason that a lot of the labs, when we interpret them, we don't know if they're fasting. So at this point in time, the coach program does not need labs at all. If you get them done, if they're covered and there's something easy to do for the family, great, send them to us and we'll review them. We use them sometimes when families go through our initial class and opt out. We look through those lab tests to make sure we don't need to follow them for a secondary problem, a comorbidity. So in general, I think you should watch signs or symptoms. For example, if they're peeing a lot, they're drinking a lot, and mom has diabetes, then an A1C would be appropriate. But otherwise, no labs required.
Did you mention the problematic issue with insulin levels?
Yes. She's so proud of me. Next question.
A genetic question.
Dr. Sellers was on call. Sorry, we'll try.
Yeah, so for George or KCP11, I feel like a lot of times we order or see the result as a fish. And do those miss a lot of them? And is that have clinical implications? Or should we be ordering something else?
Oh, you're looking at me?
No, I'm not looking at anybody but me.
Well, okay.
I would call it genetics.
I mean, a lot of our kids come through the hospital because they've got congenital heart disease. And so I don't know if you guys are aware, but every single child in this hospital with any kind of congenital heart disease gets a microarray. So a lot of these get picked up on those microarrays. Okay, so are you talking about a child who is presenting later and you're picking them up because they've got hypocalcemia, something like that?
Yeah, that may be a time. I think with the calcium issues would be more if they're not in the PCCU or
Right.
PCCU.
Then I would call genetics.
Sorry, I will tell you the way it used to be when I was a fellow. You would choose a genetic test. It was very limited, of course, because this was years ago. But nowadays, because we have this huge array of possibilities, and they control how we order them, it's very, very difficult to get a genetic test done. So we don't have a whole lot of experience with it.
And if there is some child who has hypoparathyroidism, there are actually hypoparathyroid panels which include DGeorge testing or 22q11, I should say, testing in them. But again, I would involve genetics at that point.
Within the Coach Clinic, what is, after everything you had mentioned, it seems like you discussed everything that you addressed with the child itself. What things have y'all talked about, like addressing the culture of how the parent relates to food, or what their component in all of this is? Just because I find in clinic, like I just spin my wheels with these families. If the parents won't do anything.
I would like to say that's a robust part of Coach program, but it is not. We do encourage and incorporate questioning so that the family is evaluated and included in goal setting. But I, like you, have had the same problems. I mean, we see kids in clinic where they're 15 or 16 and parents think that they should be on their own and mom and dad are over there playing on their phone. And it's very difficult to engage. And that's one of the gestalt pieces we use to decide in the back of our mind as whether or not we should be more aggressive or less aggressive, kind of start slow or start with something a little bit more meaningful with them.
Do you think that there's any room, or do you think that there's any opening in the future that there might be more like a family-centered clinic model, like pairing with family practice or internal medicine with pediatrics to like address a whole family?
I would say there is always room for improvement. How that logistically would fit into a program like ours is a mystery to me. I will tell you that I've had conversations with all sorts of providers and encouraging them to kind of incorporate themselves with us and with psychology within ACH to help us with those kind of things. And it's like turning that Titanic in a parking lot. It's very, very slow, very, very difficult, but it is an excellent idea. Anything else, guys?
What should a PCP do if they know that there's like a newborn baby or a young child and there's a family history of thyroid cancer?
So there are very specific thyroid cancer syndromes which will lead to familial thyroid cancer. So in those cases, it would basically depend on what the condition is. So something like multiple endocrine neoplasia. So most likely the kid they will have genetic changes in the gene, and ATA kind of guides our management there again, because depending on the type of mutation, depending on the code change, they have these risk criteria, that is a low risk mutation, moderate risk mutation, or a high risk mutation, and then the surgery and follow-up is planned accordingly. So all these genetic syndromes, if you do have a parent, if there's a family history, we would definitely like to see the kid so we can evaluate what exactly is the risk to the baby, get the genetic testing done for the child itself, and then go from there for the monitoring.
And to add one tiny little thing to that, because this is a practical
Issue. If you know what the actual mutation for the parent is, the sequencing for the children becomes much cheaper, because then they can do targeted sequencing, and sometimes that can drop the cost from $3,000 down to maybe $150. So it's actually very doable when you know what the actual mutation that the parent has.
I'll give you one example because I just saw the child in clinic yesterday. So this child has moderate risk mutation for medullary thyroid cancer. Maternal grandmother had it, mom had it, now the child has it. And both, I do not know at what age mom and grandma got the thyroid removed, but the child got it removed when she was 3 in University of Michigan. And because now we know that with multiple endocrine neoplasia that she has, she's still at risk for having parathyroid adenoma and things like these. So yearly I do screen her for those things as well. So that really becomes relevant in that sense, how you would, it will depend on what specific thing that is, or syndrome that is. Does that answer your question?
Yeah, I'm envisioning mom brings the kid in and she says, yeah, my mom had something wrong with her thyroid and it was a cancer, but she has no clue what it was.
Right,
Do
so
you want all those to get referred to you?
no, so it will depend. I actually do not mind, because I think at your at the level where you are, it's going to be a lot difficult to get some of those things. Sometimes I've been able to be successful in getting those records from their PCP. I'm lucky that I have worked with Dr. Bodener, so as I was mentioning at UMS, a lot of our kids will go, a lot of the adults will be there. with parent consent, I actually contact Dr. Godiner and his team myself and ask for the records and see what it is. Because if it is not really a medullary thyroid cancer, papillary thyroid cancers and follicular don't really transmit in the family as such. So it will depend, but I think once you have the family history of thyroid cancer coming up, I think the parents are already kind of very worried, and I think it's okay for us to see us once and decide whether we need to follow these kids moving on or not.
Just as an aside, I think if you're able to define that thyroid condition, and if you can, that would be very helpful to us. If you refer a kiddo who has a kind of undefined thyroid cancer from somebody in the family, that's not going to be very helpful. But if mom has a thyroid cancer, specifically medullary thyroid cancer, those are the kids we need to see pretty quickly. Papillary and follicular, not so much. Anything else?
I have a quick question. If you live long enough, are you going to get some kind of thyroid tumor?
Not necessary.
I've always heard that they've done studies where they've looked at people later in life and we all have nodules and that's what.
I mean, nodule is a different story. Like I live with 3 thyroid cysts. Bothering me? No. So maybe it is for now, I don't know. I haven't had a scan.
Any other questions, guys?
Nodule is
All right. I want to thank you very much for coming. This was our first attempt at this. We hope perhaps in the like as an annual event, perhaps we haven't quite talked to everybody about doing that. But we will keep you all up to date. I hope it was helpful. Please make sure to fill all your evaluations out. We are looking for constructive criticism. Again, this was our first attempt, so some of our logistical things were probably out of line, and we apologize for that. But in any event, to get your CME, turn in your evaluations, and see Morgan and everybody up front.
Actually, Morgan wanted me to make a plea, if you guys would. So when you go back out to the desk where you checked in, try to form a line. And what we're going to do is we're going to take your CME forms where you added up your hours. We're going to hand you a sheet that you will then use to get your CMEs. Okay, guys? So just be patient with us because we have to fill those out as you're coming through. Okay?
Thank you.